Hi everybody, Dr. Strehlow here again with another wonderful, exciting lecture on pharmacology that I like to call my superhero series. I like to do fun stuff if you don't remember any of that. Anyway, I just want to point out one of the things that you don't know about me is I do love a lot of the comic superhero and have been very excited these last several years because a lot of these were made into movies. And I'm not partial if they are DC Comics or Marvel Comics. I love them all. So I love the Flash movies, the Superman heroes. Thor's actually my favorite. You have Green Lantern, you have Captain America, The Flash, Spider-Man, Deadpool, Silver Surfer. They're all totally wonderful to me. So to show you exactly just how nerdy I can be, let's move on to the next slide. This is just a picture I took actually from my home. This is a 1950s shadow box where I have a lot of my superhero action figure collectibles on display. This is just a very partial sampling of them all. So yes, I guess I am, you could say, a nerd, but I do love my superheroes. So today we're going to talk about a new superhero that you have never heard of, and that is Gastroman. Gastroman has some wonderful adventures, and we're going to explore those when we talk about the tale of Gastroman's experiences with PUD, GERD, NERD, and other GI disorders that do require medications. I feel very comfortable talking about GI meds. My nursing background, before I became a nurse practitioner, I did work on an abdominal surgical floor, so we clearly used a lot of these medications. And I do want to point out a lot of these are over-the-counter medicines, and they still are very important in the use of GI conditions, and we're still expected to know those. So let's move on in the wonderful adventures of Gastroman. Okay, in slide 4, we're going to start talking about peptic ulcer disease. I'm going to minimize the camera again, the video, just because the slides are a little busy, and I don't want to take up space from that so that you can read. A little bit about peptic ulcer disease, or PUD. Peptic ulcer disease is very common. It is usually limited to the lesser curvature of the stomach and the duodenum. This is actually thought to be a very chronic and relapsing condition until the discovery of H. pylori infection, which happened in 1983. The ulcers actually develop when there's an imbalance between defensive and aggressive factors. On slide 5, just to show you a picture between the difference of duodenal ulcers and gastric ulcers. These are actually, an ulceration is just an open sore or a wound that is in the lining of the mucosa. So here it is in the duodenum, and here it is into the stomach area. And if you just picture this being an open sore, and we have stomach acid like hydrochloric acid that is constantly irritating this, these do not ever heal, and they can be very painful. On slide 6, I want to talk a little bit about the actual pathogenesis of peptic ulcer disease. This slide is out of Laney, and it's showing you a balance between ulcers, gastritis on one side, and healthy tissue on the other side. So healthy tissue are defensive factors, the mucus, the bicarb, blood flow, prostaglandins, and if those become out of balance, then the aggressive factors can take hold, and these are such things as H. pylori, NSAIDs, the acid, the pepsin, and the smoking. And I'm going to address all of these. And a lot of our medications that we use to treat these disorders are either at dealing with aggressive factors or working on supporting or influencing our body's defensive factors. So on slide 7, let's move on again with the pathogenesis of peptic ulcer disease, and I want to start with the body's defensive mechanisms. First of all, we have mucus. Mucus is secreted by the GI cells that form a protective barrier. Very healthy. Next thing is we have bicarb. Bicarb neutralizes the hydrogen ions that penetrate the mucus. Bicarb is produced by our pancreas and is secreted into the duodenum that ultimately then neutralizes the acid, which is usually hydrochloric acid from the stomach. Blood flow is another defensive mechanism. If we have some kind of ischemic disorder, to the GI tract. That can actually lead to cell injury, which can cause damage. So we always want to make sure there's an excellent blood flow in the body's defense. And the last one are the prostaglandins. Now, prostaglandins are actually synthesized in all tissues, and they kind of act as local hormones. Specifically with relation to the GI tract, they stimulate mucus and bicarb secretion, and it promotes a vasodilation, which is increasing the blood flow, and it will also suppress gastric acid secretion. Now, in regard on slide 7 to the aggressive factors, the first one is Helicobacter pylori, and I'm going to spend a little more time talking about this. To refresh your memory from the antimicrobial lecture that you had a few weeks ago, which I know you just also loved, H. pylori, as it's referred to, is a gram-negative bacillus, and it produces a chemical substance that's called urease. Urease is important because that's one of the substances that we measure when we do some testing of H. pylori. This bacteria actually lives between the epithelial cells and the mucus barrier in the GI tract, and it remains in our GI tract for years and years and years. Most people that do have peptic ulcer disease are found to test positive for H. pylori. Now, duodenal ulcers are much more common with H. pylori, and we find that if we can actually kill the bacteria, this will promote ulcer healing. So one of our treatments of this is using some antimicrobial agents that actually work on killing H. pylori. And we've also found that if you can eliminate the bacteria, then that actually can decrease the recurrence of that. So H. pylori is the first aggressive factor. The second one are the NSAIDs and aspirin. The NSAIDs are the non-steroidal anti-inflammatory drugs, for example, ibuprofen or Advil, naproxen or Aleve, aspirin are the NSAIDs and aspirin. These medications inhibit the biosynthesis of prostaglandins. And the prostaglandins are healthy. They also can just be very irritation, like a direct irritation of the mucosa directly. Which are why these medications are often, we tell patients you need to take this with food, so that because you're getting this direct absorption into the GI tract that can irritate the mucosa. Gastric acid is another aggressive factor, and we need to have the acid for an ulcer formation. Pepsin, another enzyme which is in gastric acid, can be very problematic, and smoking is another aggressive factor that actually delays ulcer healing. On slide 9, the overview of treating peptic ulcer disease is we have several goals. One, we want to alleviate the patient's symptoms. They have a painful stomach, it's very disturbing, and we want to give some kind of medication or treatment that's going to make those symptoms go away. Second of all, if they have these ulcers, we want them to heal, so we want to do things that are going to promote that. Thirdly, we want to prevent any complication from an ulcer, because it may just be in the lining, but it can keep going all the way through the mucosal into the wall and doing a lot more damage, namely GI bleeds. And then fourthly, if they do have this and we can treat it, we want to prevent any kind of recurrence. On slide 10, let's talk a little bit about H. pylori, the bug. Now, you remember from my little antimicrobial lecture, I brought in my little Thai Beanie Baby microbes. This is the little H. pylori version of that. Here's it on an electron microscope. And so H. pylori is a gram-negative bacillus, and it has two layers. It has a cytoplasmic membrane, and it has a thick wall, cell wall. So antibiotic choices that are very effective at the H. pylori are amoxicillin, clarithromycin, metronidazole, and tetracycline. But what's important to note is none of these are effective alone. So these antimicrobial agents have to be used in combination of some form. A quick review again from week 1. Amoxicillin, broad-spectrum aminopenicillin. It's a cell wall synthesis inhibitor. It's very effective at a neutral pH. Clarithromycin is one of the macrolides. Example of that is Biaxin. This is a protein synthesis inhibitor. These are the drugs that can cause the QT interval problems in the cardiac cycle, especially if they're taken with other cytochrome P3A4 inhibitors. Metronidazole or Flagyl is a prodrug, and it's activated only by anaerobic bacteria. It too is a cytochrome P3A4 substrate, so we have to be very cautious with drugs that induce this enzyme. And the fourth antimicrobial agent is the tetracycline. Tetracycline is broad spectrum. It is another protein synthesis inhibitor. It is bacteriostatic, so again it suppresses the microbes, does not necessarily kill them. We need the body's immune system to take over that so that you can get the continuation of the elimination of the microbe. And absorption of this medication is certainly reduced by food. So the tetracyclines we want to take on an empty stomach. On slide 11, let's talk about the first drug that's used to treat, and this is bismuth. Bismuth acts topically to disrupt the cell wall and binds to enterotoxins. We commonly know this as Pepto-Bismol, and I apologize of not being able to do this lecture and having you all in class, because this is the lecture I bake cookies for, and so this is one of my little cookies down here in the corner that I kind of put pink frosting on it to make it look like a little Pepto-Bismol. So I'm sorry about that you're missing out on that wonderful little tidbit of class. So bismuth binds to the mucous membranes. It disrupts the cell wall topically. It binds to the enterotoxins. It inhibits that urease activity, which H. pylori creates. One of the things that Pepto-Bismol will do is it will cause a harmless black stool coloration. So sometimes patients don't know this. And if you want to just think in your head, what kind of conditions would we think of if a patient came in and said, I had black stools? I can't do a show of hands here, but hopefully you guess some things of like a GI bleed. An upper GI bleed will usually cause a black tarry stool because it's been digested, as opposed to a lower GI bleed. So for example, like hemorrhoids, where we might see bright red in the stool. So if they have a black color, we think more of an upper GI bleed, which hence would be like the peptic ulcers. So if we did not ask the patient what kind of over-the-counter medications are you using, have they used Pepto-Bismol, that could be a very important lead, giving us information on the condition that the patient is experiencing. Pepto-Bismol probably coats the stomach. That kind of creates that protective layer. It's possible that it can stimulate prostaglandins, mucus, and bicarb secretion. And it will actually decrease the liquidity of the stool due to the salicylate inhibition of the intestinal prostaglandins and chloride secretion. All right, here's a little true or false question. So does diet play a major role in ulcer management? This is actually a false statement. There really is not any convincing evidence that ulcer diets or caffeinated beverages can promote ulcer formation or interfere with recovery. Now again, we're just talking about peptic ulcer disease and diet at this point. Slide 13, true or false? Smoking is associated with an increased incidence of ulcers. This is a true statement. Slide 14, another true or false? Alcohol contributes to peptic ulcer disease. This one sometimes is a tricky one. This is actually false. There really is not any hard evidence that alcohol per se does contribute to peptic ulcer disease. However, if a patient were to notice some kind of association or exacerbation when they drink, then common sense would just tell us to have them to stop drinking. And just to refresh your memory from chemistry, that alcohol and water are the only two substances that are directly absorbed by the stomach. Everything else has to get broken down into the intestinal tract. All right, last true or false question. Little puppy kisses and kitty kisses can give us H. pylori infections. This is possibly true, but more than likely it's actually false. What is interesting is both dogs and cats have their own special type of Helicobacter in their stomachs. And as pups and dogs can catch it from their mother and have like a gastritis, and when they grow up, the Helicobacter appears to be fairly harmless. However, dog and cat Helicobacter have been found in humans, but actual clinical disease has not been shown. Generally, we'd probably suggest not letting our pets lick us on the face or mouth as much as we love that, because we clearly are getting some of their germs. All right, next slide. Next group of drugs that I want to talk to are the histamine 2 receptor antagonists. The H2RAs are usually our first drug of choice when we go to treating peptic ulcers. They will promote healing by suppressing the secretion of gastric acid. And the H2 receptors are actually located on the parietal cells of the stomach. Drugs in this category are cimetidine or Tagamet, ranitidine or Zantac, famotidine, Pepcid, and nizitidine or Axed. So here again, when I talk about, oftentimes every time I go grocery shopping into the pharmacy, I'm always going up and down aisles and looking. A lot of these drugs are now available over the counter. So you can see the Pepcid, the Prilosec, the Zantac. So I think this is a great way that you can learn medications, because oftentimes they come out, and these are great examples. These drugs used to be prescription, and now in certain select doses they are available over the counter, and that's one way that can help you keep up on all of that. So slide 17, this is a picture of Laney, and kind of shows you where these drugs work. So you'll see this slide several times as we go through these medications. We have actually the parietal cell of the stomach, and what we're working on right now are the histamine 2 receptor antagonists. And so they actually block this histamine 2 receptor here, which ultimately then leads to this hydrogen potassium adenosine triphosphate pump that actually then pumps hydrochloric acid out of the stomach. Or I should say out of the parietal cell into the stomach. So the H2 receptor antagonists then block this little histamine 2 receptor here. I want you to remember too that there are different histamine receptors. Hopefully you remembered last quarter in the respiratory lecture that the most common histamine receptor that we are most aware are the histamine 1, which are the ones that cause a lot of the allergies. So a lot of the antihistamines, the Benadryl, the diphenhydramine, some of the non-sedating and antihistamines work on histamine 1 receptors. And now we're talking specifically about histamine 2 receptors in the gut. All right, slide 18. The prototypical drug in the histamine 2 receptor is cimetidine or Tagamet. This was actually one of the first that was approved. So cimetidine blocks the histamine 2 receptors by decreasing the volume of gastric juice and ultimately the hydrogen ion concentration. Remember, this does not block the histamine 1 receptors, as I just mentioned, in allergies. This is very particularly effective against nocturnal acid secretion, which happens a lot of times. People lay down at nighttime and they wake up because they have the kind of like the heartburn, the ulcer disease. So these are good drugs to help with that. This is a competitive antagonist of the histamine 2, and it is fully reversible. You remember the competitive, non-competitive actions of medications. This will suppress our body's basal acid secretion and secretion that is stimulated both by gastrin and acetylcholine. Now, food will decrease the rate of absorption of this drug, but not to the extent. So they can still take this medication with food, but it will just be a little slower absorption rate. This drug will cross the blood-brain barrier, and because of that, some of our adverse events that we see are central nervous system effects. It has a short half-life of about 2 hours, and we're going to use this in gastroesophageal reflux disease, or GERD. We use these in gastric and duodenal ulcers, Zollinger-Ellison syndrome, which I'll mention a little bit shortly, and aspiration pneumonitis, and also heartburn. Now, cimetidine offers the theoretical benefit of reducing both histamine-induced cardiac arrhythmias, which are mediated via histamine 2 receptors, and an anaphylaxis-associated dilation, vasodilation, that's mediated by a histamine 1 and a histamine 2 receptor. So there may be instances when you have a patient who is undergoing an anaphylaxis, and the physician will order you to give some IV Tagamet push because of this anaphylaxis reaction that is somewhat involved with some histamine 2 receptors. Slide 19, Zollinger-Ellison syndrome is a gastric ulceration. So here is, you can see on endoscopy, a lot of these open ulcerations. This is a disorder where increased levels of the hormone gastrin are produced that causes the stomach to then produce an excess of hydrochloric acid. Often the cause is a tumor, which is referred to as a gastrinoma of the duodenum or the pancreas, producing the hormone gastrin. Gastrin then causes an excess production of acid, which leads to these peptic ulcers in about 95% of patients. It's not a real common disease, but it certainly is prevalent enough that you may run into this. Continuing on with slide 20, with cimetidine, the adverse events of this will bind to the androgen receptors, which can produce a blockade. So you can have such things as gynecomastia, as seen in this picture, and if you're a guy, you're not too excited about having male boobs. It can also decrease the libido and lead to impotence. Remember how I said it kind of crosses that blood-brain barrier that can lead then to some CNS side effects. So we see things like confusion, hallucinations, depression, or even actual excitation. If this is given intravenously, the blood pressure can bottom out, so we see hypotension, and can actually see some dysrhythmias. So this is usually infused over a slow period of time. And this drug has mega drug interactions, as you can see here, by affecting the cytochrome P450. And you'll recognize a lot of these common drugs that are just classics: the warfarin, Coumadin, phenytoin, Dilantin, seizure medicine, some of the cardiac meds, carbamazepine, theophylline, another one of the respiratory drugs. And so what cimetidine does is it can increase serum concentrations of these other drugs. So we have to be very careful with this. Slide 21, other drugs in this series are, we just talked about cimetidine, so now we're going to talk a little bit about ranitidine, famotidine, and nizatidine, Zantac, Pepcid, or Acced. So these differ from cimetidine in that they are more potent and we have fewer adverse events and there's fewer drug interactions. So this often happens when you have a first drug that comes out on the market, then newer drugs get formulated to either improve its effectiveness, decrease its adverse event profile. Give you an example of this. Ranitidine is 5 to 10 times more potent than the cimetidine. Famotidine and nizatidine are 20 to 50 times more potent than the cimetidine. These do not block the histamine 1 receptors, so they're not necessarily effective for allergic reactions like the respiratory allergies. They, like cimetidine, are absorbed at the same rate, either with or without food. They have less CNS effects. They don't bind to the androgen receptors, so your male patients are very happy that they don't have male boobs. There's a weak cytochrome inhibition, so we don't necessarily see those interactions with the other drugs. And peak levels can occur in about 45 to 90 minutes after an oral dose. And the last slide in this series of this little part 22 is just want to talk about the long-term safety effects. Patients have been on these drugs for long periods of time. We have very stressful lives. We're graduate students. We're getting a master's degree in a field that is totally unrelated to us, called nursing. We have no experience in this. We're trying to work full-time. We have families. This can be very stressful, and just on top of like our other day-to-day environment. So many people are taking these medications all the time. So we're now seeing that there are some cognitive impairments that have been shown in long-term users of this that has been linked to dementia. So a general thing that we always do with medication is if you don't need to be on the medication, let's get you off of it as much as possible and try some other kinds of issues. All right, let's move on to part 2.